All right, so I'm recording this just so everybody knows that. And let's go ahead and get started with the episode Quality Improvement Program meeting this morning. And I'm going to make some brief introductory comments, and then we're going to turn it over to the people who actually know what's going on, and that's the staff at the HSCRC. And I did just want to start, I usually do this at the end, but I wanted to do it at the beginning. So if people who didn't drop off hear it, I just wanted to thank Tequila and Maddie and everyone who've been working on this. This has been a lot of work for a long time, and also thank the folks who worked on it before they worked on it. And the HSCRC staff has done an incredible job working with CMMI and all the stakeholders and everybody, and have really, really deserve appreciation. And I appreciate generally all the state employees, because they all work too hard and can make a lot more money in the private sector, and we should all thank them generally. The second thing I wanted to do was just kind of give a high-level overview of what we're doing today, because I didn't want to bury the lead. And we've got really exciting good news today. And there are three things that I wanted to highlight. First, and this has been asked by several people, I think we're going to learn a little more about the fact that we have worked out the Prometheus issues. And today we're going to hear about how we are going to have alignment with what CareFirst is planning on doing. And Maddie's going to be able to help folks who want to figure out how to use Prometheus, and we'll talk about that today. That's positive news, obviously. The second thing is that it looks like CMMI is going to approve this with no downside risk in year one, which is huge, obviously, because it means that we can kind of get our sea legs and figure out what we're doing. And I think that's an incredible thing for participation and getting people involved. And third, it looks like CMMI is going to approve this as an advanced payment model, which means physicians can get the 5-point bump in Medicare. So the one thing I'm going to ask in advance, given the facts I've just given you, we really, really need to encourage the three specialties to sign up, because really there's no downside. In fact, there's really only upside, because even if you don't achieve savings on the bundles, you're going to get the 5-point bump on Medicare. So I really would ask that if you know a cardiologist, a GI doc, or an orthopod, talk to them and get them excited so they can start signing up later this summer. And we're going to do outreach and activities, but this really come around well, and I'm very excited about it. So having said that, I am going to go ahead and turn it over to Tequila, who is going to start us off and get us going today. Thanks so much, Tequila.
Thank you, Gene. And I want to echo our thanks to you specifically, Gene, and to all your team at MedChi for being such wonderful partners with us as we work to build EQIP and actually make it a successful program in Maryland. So just to start, by way of introduction, again, my name is Tequila Terry. I think most of you I've either talked to or exchanged emails with at some point, but I'm with the Health Services Cost Review Commission. I lead our Center for Payment Reform and Provider Alignment, and our team is really excited to be here today to provide you with the latest information on EQIP. So if we can go to the next slide. What we have lined up today is a couple of key updates to let you know where things stand in the development of EQIP. We're going to start with a few administrative updates, which I'll share on some of the key dates we want to remind everyone of, particularly for this group and the meetings that we are going to be having throughout 2021. And to Gene's point, talking about our goal to make this program a multi-payer program, both to foster value-based payment models throughout the state, but to also make it easier for physicians to participate. So we'll talk about that. Then Maddie Jackson-Fowle and Jessica Heathop from CRISP are going to tag team and talk about specifics around EQIP participation, what's involved in getting enrolled, what participation in year one will look like, and then more specifically, talking about where we are with policy and methodology confirming our final design decisions for year 1 on incentive payments, as well as quality policies. So we've got a lot of information planned for you today and really looking forward to a great conversation. Next slide. So just to remind you of some important dates and upcoming information to be aware of. First, I want to underscore the importance of these meetings. The EQIP Subgroup is really the #1 forum that we are using, at least for now, to push out information, to share information about what the EQIP design is, what the timeline is, and opportunities to participate. So this meeting, going forward for the remainder of the year, is going to move to a monthly meeting series. We're going to have this meeting the 3rd Friday of every month from 9 to 11. And so you can expect to be receiving information on a monthly basis about what we're doing. So if you could be so kind as to note on your calendars that the next meeting is on May 21st. And if you know of people who need to be added to this meeting or are interested in getting on the distribution list, you know, Barbara Fitzgerald at MedChi is managing the distribution list. So please reach out to her. And again, the idea is that this is going to be the place to get a great deal of information about what to expect. Additionally, we are starting to build up our team at the state to be able to support the program. And so we have established a new mailbox so that if you all have questions about EQIP, the design, the timeline, or generally anything, you can feel free to email us at the email address that you see on the screen, equip@crisphelp.org. We'll be working really closely with the CRISP team on this. So please do make note of that email address. And then finally, just want to highlight a couple of the key dates to be aware of. We've shared this information previously, but we'll probably in each meeting reiterate these dates. So the most important thing to make note of is July 9th is when the enrollment period opens. So we want to make sure that that is flagged. That's the opportunity to get enrolled in EQIP, and it runs through September. And then throughout, beginning in August, we expect that EQIP entities or the practices and the individuals will start to pull together information about preparing NPIs and other information that's needed for CMS vetting. So this summer, there's going to be a lot of activity going on with EQIP, but in particular, July 9th is the kickoff date for enrollment. And then October through December, for anyone who signs up to participate, we will be working with you all on contracting, episode and intervention selection, and all of those final details for the January 22 program start. So each meeting, we're going to reinforce these dates just to make sure that you're aware of the importance of the timeline. Some of these dates are really written into stone because they are established by CMS. So we want to make sure everyone is well aware. Next slide. So then finally, I just want to highlight something that we are really very excited about. As a state, we really are very focused on encouraging the adoption and proliferation of value-based care models and payment programs across Maryland. And so given this, I'm excited to announce, as Jean alluded to, that we have now formalized a demonstration program with CareFirst to align our Medicare EQIP program with CareFirst programs. And this is really important because it marks the first time that we as an agency are working with a commercial payer to align our program, really, again, with the goal of, one, getting more value-based payment models across the state, but then two, as I said, making it easier for you all. We want to make sure that it is easy to participate, and to the extent we can align conceptually with payers across the state so you don't have to have separate rules and separate programs. for every payer that you work with. We want to be able to support that. So we have aligned our episode program definitions so that the episodes of care program from CareFirst and EQIP can really have parallel designs and incentives. As Jean mentioned, the Prometheus episode grouper and methodologies are actually going to be used in both programs. So that again makes it easier that some of those underlying principles and methodologies will be similar. The incentive payment and other policy decisions will remain separate where appropriate, but conceptually, we really want to have consistency to make it easier to participate in all of the programs. And then specialists will have the opportunity to receive rewards on cost controls and quality improvements across both Medicare and CareFirst, which we think is a really important opportunity. And so we're starting with CareFirst, and we hope that we can get other payers to have similar sort of designs and agreement to collaborate on sort of a statewide framework. So we're really, really excited about this collaboration and opportunity to, again, make it easier to participate across the state. So with that said, I'm going to stop and just see if there are any questions just on some of these administrative overarching items to be aware of. Any questions at this point?
Tequila, this is Jesse Pines here. One question I had about the work with CareFirst. How does, I don't know if you can briefly talk about how EQIP interacts with what CareFirst is planning to do on the ACO side, because I know that that's going to be directly with the hospitals and the physicians are not involved in that. I don't know if you have any thoughts on that.
Yeah, so I think, and Maddie, feel free to jump in here, but again, we are focused on the episodes of care program, the physician-based program, really as a starting point. To the extent that there will be other opportunities to align in the future, we'll absolutely consider that. But for now, that's our starting point. And Maddie, if you want to jump in, and I think there's probably a couple of folks from CareFirst on as well. If you have any thoughts here, feel free to jump in.
Yep. So technically, the ACO program or product that CareFirst is offering is separate from their episodes of care program. So this will run, obviously those interact a bit, but someone from CareFirst can jump in as well. But this is a separate program from the ACO program that they are offering. So we are running alignment with the episodes of care program from CareFirst, not the ACO.
Dr. Pines, does that answer your question?
Yeah, I mean, I guess the question is if someone is in the ACO and then comes in with one of these episodes, how does that work? That would be my question. I'm not sure if someone knows the answer to that.
Yeah, I think that would be a participation question for CareFirst. I wonder if Erin is on from there, but I can relay that question back to them and get you an answer there, Dr. Pines.
Great, thank you.
Hi, good morning. Gabby's on.
Oh, hi, Gabby.
Dr. Pines, hi. Happy to take this offline. We do have a methodology for making sure that our independent practitioners can participate in both programs if interested. We keep the attribution logic separate.
Okay, thank you.
Thanks, Gabby.
Great, thank you for that question. Any other questions? Okay, well then what I'll do is now I'll turn it over to Maddie Jackson-Fowle, who's a member of our team, to talk about EQIP participation in year one. Take it away, Maddie.
Thanks, Tequila. So I'll kick it off with some technical stuff with CMS, and then I'm going to turn it over to Jessica Heslop, who I think is the first time we're introducing her to this group. But she will be leading the learning system and kind of the CRISP management with our interface with CRISP, our Health Information Exchange. So we're excited to have her on board and introduce her to you, and she's going to walk through some participation parameters as well. So very quickly, we do want to mention that EQIP will be a track under our Care Redesign program that we have been running since 2017. This program grants fraud and abuse waivers to hospitals to allow them to provide incentives and resources to care partners or other providers in exchange for kind of aligning on value-based payment to improve quality and reduce the growth of healthcare costs. EQIP will technically be a track under CRP. And the reason we're going this route is because due to COVID, things at CMS have slowed significantly, and getting a new program through clearance just wasn't feasible on the timeline that we would have wanted it for as a state. What this means is that we will be utilizing a CRP entity or a hospital to be the vehicle for contracting and payment to care partners or physicians. However, the HSCRC is responsible for all EQIP policy, administration, and that includes incentive payment calculation and incentive payment determination, right? So we will have a transparent process directly to providers so they know what incentive payments to expect and how their performance is assessed under the program. Essentially, this CRP entity or hospital will be used as the vehicle to distribute payments. However, they won't have any control over the amount or the determination if an incentive payment should be made. And this slide kind of breaks it down a little bit further. Again, the CRP entity or a Maryland hospital will have to contract or sign a contract with the care partner physician. It is not limited to who has privileges at the hospital or has a pre-existing contract in the hospital. It's open to all Maryland specialist providers in the state. And then oh, go ahead. And again, this is the entity that will be paying checks directly off of the HSCRC determination. The specialist physicians and the care partners are still the really main focus of our program here. They will be the ones that trigger episodes and perform the care interventions, determine how they are going to participate in the program. They will be expected to sign a care partner arrangement with the CRP entity, but again, that will be dictated by the HSCRC and overseen by the HSCRC. The care partners will receive normal fee-for-service payments from Medicare. They will bill normally. And then this incentive payment will be assessed after the performance year is done. And it will kind of be a bonus check on top of your normal Medicare revenues. They will also, if participation in this program, and Jean mentioned this at the outset, any care partner in this program will be eligible for quality payment program status. So that means that you will get that kind of MACRA 5% bonus on top of your incentive payments in the program. As far as the state goes and CRISP, we are responsible for calculating all episodes, monitoring performance, and determining the incentive payments, as I mentioned. And then we will maintain all of the monitoring and reporting requirements to support the CRP entity. So we're really entering into a partnership with this Maryland hospital, and we're very lucky for their partnership. But for all intents and purposes, we are going to be the ones that are facilitating care partner enrollment, operating learning systems, having that back and forth with physicians in the program, and making sure that the policy and methodologies are transparent so that physicians understand how their performance is assessed in the program. Are there any questions on this piece? Great. So I'll turn it over to Jessica, who's going to walk through how we get you into the program.
Thanks, Maddie. And hi, everyone. I don't think I've been formally introduced to the group, but I am Jessica Heslop. I'm program manager at CRISP, and hopefully will be one of the people you'll hear from a lot about how to actually get into the program. And as we develop the steps and sort of the deadlines coming up, we'll be sending lots of reminders and try to communicate and over-communicate to make sure everyone knows what they're doing. So really, I'm going to take a couple slides and just kind of go through how we're going to actually operationalize this program, and specifically what you all as physicians may need to do to actually participate in this. So you'll start here. First are some roles and definitions. As I explain this, keep in mind, you heard Maddie use some of this terminology, and we'll continue to use it. It'll flow through to the portal as well. So hopefully this can just kind of serve as just a mini little glossary as we talk about some of the ways we are categorizing people. So first, let's start with the EQIP entity, and you can see that here on the box up top. So the EQIP entity essentially is either an individual or multiple providers who elect to participate in EQIP. That EQIP entity is the level that the performance evaluation occurs. And additionally, the one incentive payment is made at the EQIP entity level. So you can see, again, a physician can choose to themselves participate by themselves, and then means that individual is an EQIP entity, or multiple physicians can choose to come together and form an EQIP entity. So that individual physician will be referred to throughout this as a care partner. And really that essentially is at the NPI level who chooses to participate. It's important to stress that because each individual physician, whether they're participating by themselves or with a group of other physicians, must sign a care partner agreement with the CRP entity. And again, so want that to be important. So we heard prior that EQIP is recognized as a CRP program, and that is why that care partner agreement is necessary between the individual physician. And additionally, that's why the incentive payment will come from a CRP entity to the EQIP entity. That's a lot there. I'll pause, a lot of different entities and words. So if there are any questions, please let me know.
So maybe one point I'd make is that since the window to sign up is not going to be incredibly long, larger organizations that have a lot of physicians might want to start thinking about making sure they're ready to sign all these physicians up. Because what you're saying is that if I'm, to pick on University of Maryland, if I'm Maryland academic physicians and I want all the orthopods to sign up, I need to have each one of them individually. You can't just have the EIN for that group sign. That's what you're saying, right, Jessica?
Yes, so yes and no. So, and we'll talk a little bit about what's required for participation. So when you enroll in the portal, you can enroll as a group, and a lot of that can be done at a group level. So again, each individual physician may not need to do that. However, the one thing that, again, we can't stress enough that's truly required at that individual physician level is the executed care partner agreement prior to the start of performance year one.
Yeah, and to add on to Jessica there, so that small window, Jean, from July to September is the window to submit the list of physicians that will be participating in their NPIs for vetting to CMS. We will not be expecting that the contracts will be executed by that September 1st deadline. We actually will be doing contracting throughout the fall, and we'll provide more updates on that, but we are not expecting that every individual physician needs to sign a contract by September 1st, just indicate that they would like to participate in the program with an EQIP entity through the portal. So that way we can submit them to CMS to ensure that they're ready to start the program in performance year one or January of 2022. So the contracting will occur after we get everyone kind of all the NPIs and names into the care partner portal.
Yeah, exactly. And we'll talk a little bit more about timeline as well.
Could you possibly give an example? I'm having a little bit of difficulty figuring out the difference between the CRP entity and the EQIP entity. I'm sorry. Thank you.
No problem. So the CRP entity is simply an administrative hospital that will be actually giving the incentive payments to the EQIP entity. So they are not a participant. It's truly on the administrative side. The EQIP entity are those that will actually be enrolling into EQIP and evaluated on the episodes that they trigger over the performance period. So it's really basically what we're saying is you will not be receiving payments directly from the HSCRC, you will be receiving payments from the CRP entity. And that is why the care partner agreements occur between that CRP entity and the individual physicians or care partners.
So if the EQIP entity is a large physician group, you know, like the orthopedic group that's statewide, and the CRP entity is the hospital, it's not the EQIP entity that has to contract with the individual care partners. It's the hospital CRP entity that has to contract with the care partners, even though the CRP entity is not really the entity responsible for performance. They're just the entity responsible for payment. Do I have that right?
Yes. And I think there's two qualifying things that we can help clarify. So there's one CRP entity for this entire program that's selected and will be the ones giving incentive payments to any EQIP entity that joins.
Okay, I do remember that. There had to be a hospital in Maryland that was willing to administer the program on behalf of all Maryland hospitals. So this doesn't mean that each Maryland hospital is going to have to contract with the care partners in their area.
That's correct.
Okay, thank you.
And then the other, I think, point is that at the EQIP entity level, and we'll kind of go into that a little bit in the next couple slides, you will actually be able to determine where the payment goes to. So that is at the EQIP entity level. And again, that one singular CRP entity hospital that's selected will simply be doing that transaction. So hopefully that helps clears it up. So it's not, it's not like each individual hospital or each individual provider has to go running around. We will be really helping usher this process through to get the care partner agreement signed. Again, providing that transparency about the expectation of when and what sort of incentive payments will be after a performance year is completed.
So how does the dollar amount that's paid out to the EQIP entity get attributed, so to speak, to the hospital that is impacted in the process of the program being administered in terms of efficiencies in the cost of care in their area? Are those dollar amounts that are paid out by the singular CRP entity facility then attributed back to the hospital where those providers, anyway, I'll stop.
Yeah, it's some good questions. And we can also, the next slide talks a little bit of administrative proxies, which I think may touch on that. But ultimately there is one payment, if obviously you meet those qualifications, one payment to the EQIP entity. How that incentive payment is either distributed to, let's say, a hospital that's taking on a fair amount of administrative burden, or throughout the individual physicians that are part of that EQIP entity, is up to that entity, that EQIP entity. So that's sort of the summary of it's up to you guys. However, administrative proxies, which I think you're sort of touching on, is obviously there's a group of physicians, but there may be someone that's really helping manage the program or taking on significant responsibilities or resources associated to have success in that. And if I answered, I want to pause, make sure I answered your question. I can kind of jump into administrative proxies, and hopefully that will answer a little bit of as far as the management support.
No, that was helpful. I wasn't thinking so much of the EQIP entity making a payment to the hospitals. I was just wondering if there was some way that this was adjusted in hospital rates under the MPA.
There will not be an adjustment under the MPA. So there will be, we are executing these payments CRP entity through the MPA, but it'll be a net neutral to that one hospital. The rest of the hospitals will be unaffected.
And just for the physician side, so physicians on the call don't get confused. The physician fee for service payment will not change. They will still receive that just like they normally do for whatever the CPT code is. And the benefit for the physician group, and obviously it'll be different depending on if the group is a group where the doctors are employed by a hospital or a private practice group, would be only the additional benefit would be only if they got savings. And then the secondary additional benefit is this is a qualified advanced payment model. So that means in the future year, you would get the 5-point bump under MACRA in your Medicare payments. So that's the physician side on the payment, which is separate from what Jennifer was just asking about, which were all very good questions on the hospital side.
Okay, thank you guys. And I think that leads really great into administrative proxies. Thanks, Maddie. As we mentioned, an EQIP entity can select to basically delegate the management of the EQIP program to an administrative proxy. That decision is really up to that individual physician or group of physicians. We do want to stress that the administrative proxy themselves will not be part of the CRP participation agreement. Again, that is only between the individual physician or NPI and the CRP entity. And also that the structure of payments flows from that CRP entity to, or sorry, from our CRP entity to the EQIP entity, and they all decide on where that payment is going. So any type of basically contractual relationship that a group of physicians or an individual physician may have for the administrative management occurs outside of the formalization agreements in EQIP. And that's sort of stressed here. So administrative proxy roles, really, this is the data analytics opportunity, looking at the quality improvement, other ways that they can look at optimization of their operational or financial practices. So again, depending on the structure now that may, for an employed physician group, you may already have that, and an administrative proxy could be a practice manager, an administrator, it's those types of roles. And we're committed to giving them access from a reporting standpoint to be able to make sure that administrative proxy has the tools that they need to be able to provide that assistance.
Can you give an example of who would be an administrative proxy? Like can you give an example of a structure of how this would work?
Yeah, I'll give two examples. I'll give one of like an employed group. So let's say, I think someone already picked on so let's pick on all of their orthopedic surgeons come together and form an EQIP entity. And let's say their administrator of orthopedics is their administrative proxy. That person would be granted access as far as updating the portal for enrollment, things like that. So can take off some of the burden on the individual physicians. However, that administrator will not be signing any agreements. That agreement still is at the individual physician level. However, they are obviously going to help throughout the year, keeping people on track. And there likely will not be any additional contractual relationship since there is an employed model already. Now, for let's say an independent group, a large independent group, let's say they want to contract with, I'll say Fusion 5, and Fusion 5 will be granted, again, those administrative proxy in the portal, or, you know, to be able to do certain things like select which NPIs are included in this. They will have access to the data as far as baseline and performance, and provide that group opportunity on how to, you know, hopefully get an incentive payment. However, again, can't stress this enough, the relationship between Fusion 5 and that independent group is going to be outside of the formalization of EQIP. So if there is a management fee, let's say, or some type of shared payment within the incentive payment, that is between the EQIP entity or that group of physicians and, I said I pick on Fusion 5 and Fusion 5. So that's, I think, the key qualifier here is it's really done, or the decision and the management of that administrative role is being done outside of the formal EQIP process. However, we will ensure that from an access and data management standpoint, that administrative proxies have what they need to assist the physicians. Did that help?
Yes, thank you.
Okay. Okay, so Maddie, I think we're the next one. Okay, so participation requirements, kind of important for everyone. So really we kind of are bucking this into three different things. The first and most important one is that any care partner has to qualify with CMS. And what that means is they have to be licensed and enrolled in the Medicare PCOS program, as well as be using a certified EHR technology and utilization of CRISP or Maryland's Health Information Exchange. Again, can't stress enough here the importance of being part of the program for each individual physician to be up to date, and we must be able to match you in the PCOS enrollment system. So that is something that, you know, someone could, if you have a large group of physicians, just ensuring that that is as up to date as possible. That's something that could be potentially looked at now. The next one is actually the enrollment process. And this is where you're really determining who is in your EQIP entity. So whether you're choosing to participate individually or with multiple physicians, selection of which episodes and interventions that EQIP entity will be participating during the performance year, and acknowledgement and agreement of the quality metrics associated with those. And we will go into more detail a little further on quality metrics. The signed and executed care partner agreement prior to the start of the performance year. And then, as we mentioned about the incentive payments, each EQIP entity must determine the payment remission recipient that EQIP entity will be getting. And finally, episode thresholds. So at the EQIP entity level, a single episode must have a minimum threshold of 11 episodes within the baseline period. And then across all episodes that the EQIP entity chooses to participate in, there's a minimum threshold of 50.
Jessica, do you know if under the current CRP programs, if individual physicians are required to sign a care partner agreement? I can't remember.
Maddie, you might need to tag you in there.
Yeah, so yes, the short answer is yes, they are required to sign an individual agreement. There is some group signage there, but because we can, because each EQIP entity will be determining which physicians are within it, we do need direct individual confirmation that each care partner is agreeing to participate as a part of that entity. So that's where that contracting piece comes in, where we have to have each physician sign on the dotted line. However, it will be a standard contract across the whole EQIP entity. So we hope it'll be a fairly simple process.
So just to clarify, if there was a practice that had 10 physicians, the practice can't sign the care partner agreement. It's each individual physician has to sign the care partner agreement.
Yes,
okay.
Exactly.
Just for clarification, and I really looking ahead, the procedures obviously at this point in time are all physician-based procedures, but you have provider in one segment here and physician in another. We are only talking about physicians in this program?
Yes, at this time, given the selection of the episodes, it is just a physician that would qualify for these episodes. I think that's a good.
But we are not excluded to just physicians. It's really just because we've kind of agreed to start with these specific codes for these specific specialties, and there's no other one who has an appropriate scope to do that. If in the future, as we add additional specialties, which we hope to, then it's very likely that we could have non-physicians like PAs or nurse practitioners involved, correct?
So the episodes are triggered based off of an NPI. So providers that have a national, the NPI number, and I can't remember the full acronym name, but providers who have an NPI and qualify as a CRP care partner, and there are a couple of parameters around that, will be eligible to apply as in normal CRP. Okay.
All right. So just so I've got this clear, because, for example, in HCIP, a previous CRP that protocol, that was physician only, period. Other providers could have done that. In this one, it could be potentially any provider, depending on what procedures and designation we have going forward.
At this, yes. So going forward, we can discuss opening it up, but at this time for tier 1, it will be physicians only.
Okay.
Hi, this is Dan Sedek. I just had a quick question about the episodes and interventions. Are those hospital episodes and interventions? Is that where they'll be located, or the triggering episode or intervention, if I'm saying that correctly?
So, and Jessica, I can take this one for so the interventions and episodes are agnostic to setting. So wherever these events occur, they will follow the physician their care of practice. So if a physician practices part in a hospital, part in an ASC, part in an outpatient center, all of the episodes will be triggered agnostically among those settings.
Okay, that's helpful. And is it just Medicare payment? I'm sorry, I'm just a little confused if the payment's going to flow through the CRP. I guess I'm
correct.
Understand how that flows.
Yeah. Yes, that is correct. This is Medicare only payments. CareFirst is running a program for their commercial payments, but this EQIP program is for Medicare payments only. Physicians will bill regularly under fee for service, and then we are going to base this incentive payment off of their Medicare payments in the performance period.
Thank you.
So does that mean hospital costs are included in the episode? You're probably getting to this. And if you are, I can wait till you get there.
We are going to get there, but yes, that is correct. Hospital payments will be included in the program. So just,
yeah, so lots of good questions, and I think we'll touch a little bit, dive deeper into some of the things that got brought up. So the next slide that we have is talking just about the actual timeline. So you heard us mention a couple times this July to September 1st timeframe. So what's really important here is that is the opportunity to basically signal that you would like to participate in the upcoming performance year. So it is a little bit of a short window. Some of the stuff that needs to happen to finalize enrollment does not need to occur within those 3 months, but the initial which NPIs are going to be part of an EQIP entity and which episodes has to be selected prior to September 1st. And then the other thing that we're looking at is you can kind of see here, just from a timeline perspective, we are using baseline of calendar year 2019. We've mentioned that performance year is calendar year 2022. Because we do have a claims run out, and actually even due to some of the episode lengths, you would expect if you qualify for incentive payments to be in July of your first incentive payment to be in July of 2023. So that same timeline would follow through to performance year 2 with an incentive payment or incentive payment distribution in July of 2024, and so on and so on. And obviously, you know, we will be continuing to evaluate this program, and participation opportunities may increase, you know, year to year, especially as we add more and more episodes into this. And lastly, this is really, I mean, hopefully everyone's seen this, you know, have these slides, so I won't go into this in detail, but as you know, there were 3 selected specialties to start with in performance year 1, cardiology, GI, and orthopedics. And you can see here specifically which episodes under those tracks were selected. And then the numbers at the end are the episode length. There's a lot more detail that obviously we can provide and we'll go into at some point about these, but hopefully this gives an overarching idea of the focus of performance year 1. So with that, I think I'll hand it back over to Maddie, who will go a little bit into some policy and methodology.
So real quick, on the procedure types here, would it be any surgeon or proceduralist who is involved in this care? So it wouldn't necessarily have to be ortho, for instance. It could be a neurosurgeon.
Yes, correct.
Yes.
Yep.
Okay, thanks.
This
That
is
is
Jennifer.
a very good point.
Yeah. I had a quick question. I know that there were some issues initially with the EQIP program and providers who were supposed to be granted APM status, and some back and forth with CMS and some cleanup. Do we think we have this established in such a way with CMS that we can avoid some of those issues that we had the first year of EQIP?
Yes, so we do think that we have that situation cleared up in the methodology firm with CMS. So I think going forward for new CRP tracks like EQIP, it'll all be straightforward, or more straightforward, and more physicians will be eligible. So we've gone through a process to kind of go back and fix those results. And I know we can't do it historically, but in moving forward, they will be correct.
So the threshold of episodes that qualify you for participation in this should automatically meet the CMS thresholds, or so will just signing up for the program automatically make the physician eligible as an APM, or will there be additional calculations that are done to true up whether that will apply or not?
Yeah, so I am going to speak to AAPM status in the next couple of slides. So if we can wait till we get there, but the short answer to your question is yes.
Thank you.
And we can chat through that more. Okay, so now for the more fun, or not more fun, the less fun stuff, I would say, to Jessica's side. We're going to chat through the final policy and methodology for year one. Again, we are hoping to have an iterative process with this group and the physicians who are engaged in the program to ensure that this remains transparent and then also works throughout the state. So, but this is pretty final for year one, and then I'll talk through our plan for quality. So the last meeting we actually had Change Healthcare graciously come on and walk us through what's in the episode grouper and how that works. This meeting, we really want to focus on the other side of things. So what happens once the episodes are calculated and we get that output back from the Prometheus grouper, how all of the payment policies will come together on the HSCRC and CMS side. And so this includes how we are going to set target prices, how we are going to determine shared savings and incentive payments, what the quality measures will be, how the reporting and monitoring will work via CRISP, and again, the participation specialty areas and CMS policy, and this includes the AAPM status or quality payment program status. Okay, so first off, target price methodology. So as Jessica mentioned, 2019 will serve as our baseline for the first 3 performance years of EQIP entities joining in year one. Each EQIP entity will receive their own unique target price. So this means it is based off of the way that each entity practices currently or practiced in 2019. We will trend this forward so that way it's comparable to performance year costs. And we will allow people to see the first target price at the start of the performance year, but we will continue to update and trend it forward to the end of the year. So that way, again, costs are comparable. The baseline for entities that join in subsequent performance years, so after 2022 will be the year prior. So if you join in 2023, you're going to get a 2022 baseline, and then moving forward, et cetera. So this means for those who enter in 2022, we will utilize 2019 as the baseline for at least 3 years, and we might do some updating after those initial 3 years to ensure that we are keeping costs relevant, because 2025 is pretty far away from 2019. As I mentioned previously in a response to a question, each episode will have a singular target price regardless of the setting of care. That means it's agnostic across a hospital, an outpatient facility, an ambulatory surgery center. This is because we think that the price gap between ASCs and hospitals is significantly larger under the Medicare fee-for-service schedule in Maryland, particularly due to our rate setting system. But we do want to align with the hospital incentives under GPR to kind of shift lower acuity procedures to lower cost incentives. So align that with what the hospitals are already trying to incentivize under our policies within the GPR. Again, part of the reason that we're doing EQIP is so that we have physician alignment with hospitals under value-based payment, and everyone is kind of rowing in the same direction with regards to thinking about where procedures should occur, and also, how we best achieve lower cost growth with higher quality. So are there questions? And please interrupt if there are questions. Happy to go along as we continue. And so this slide really breaks it down in total. So this is how we're going to determine the incentive payments due to each EQIP entity. So in the first step, we will do a reconciliation of performance period results. So we will determine, again, if your performance period results are less than the established target price in the aggregate. So we are going to aggregate your performance across the EQIP entity and do that comparison of target price to performance in total. We are going to need to ensure that at least 3% of savings are achieved. This is to ensure that these savings are statistically significant, not due to random variation. However, we will be paying out first dollar savings. So this 3% is essentially a check. We're 3% of savings achieved, and then we will pay out any savings underneath that target price that were achieved. We are going to also require that DIS savings are offset from any prior years. Again, for performance year one, this isn't a thing. But we will need to do this, and I'll talk about this a bit more in some further slides. We are doing this because there is no downside risk in this program, and we need to ensure that we are creating valuable results in the program. And I'll speak more to this policy in a couple later slides. Then after we determine your reconciliation and savings were met, we will determine your shared savings split. So each care partner's target price will be compared to a statewide experience and kind of annually ranked. So the more costly target prices or costly EQIP entities will have a lower rank and a lower percentile, and the more efficient providers will be in a higher rank. And what we're going to do with this is determine the amount of shared savings that we will pay out. So again, you know, if you're in that lower rank where we think that there's more opportunity to improve on the cost of care that you are providing, we will split any savings achieved 50-50. And that's our baseline for throughout the entire program. If they're in that middle tercile, we will split them 65-35. And if you're in that higher, more efficient tercile, we will split it 80-20. And what we're trying to do here is really incentivize you know, participants who are already pretty efficient to participate, but then also still, you know, provide some incentive for lower efficiency providers to improve upon their performance. From there, we'll apply a clinical quality score. So this is a 5% earn back of the incentive payment. So we will, based off of your quality performance across 3 measures in performance year 1, we will allow you to earn back a portion of the shared savings that we have determined. And I'll talk more about that in later slides. We are committed to kind of updating and looking at this policy's effect in future years as well here. Then we'll just do another quick check. We will ensure that the incentive payment cap is no more than 25% of the EQIP entity's prior year Part B payments. This is kind of a stop gain. Again, 25% of your total fee for service Part B payments in the prior year. So it's not something that we anticipate running up against, but again, we will have a stop gain in this program. And then finally, we will determine your final incentive payment. This will be paid directly to the payment remission source that the EQIP entity designates. So again, there will be one payment to the EQIP entity for all the physicians who participate or the individual physician. This will be paid in full 6 months after the end of the performance year. So there's one lump sum payment in July of the following year, as Jessica mentioned. And then again, in addition to these incentive payments, as a part of being a part of the program, Medicare will pay a bonus to physicians and increase your rates in future years under that QPP program. So this is the full breakdown of how we plan to determine incentive payments. We will tell each provider what their shared savings is, what their CQS score is, if they have an incentive payment cap, if they run up against an incentive payment cap, and then again, what is the final incentive payment due to your EQIP entity at the end of the year that you should be receiving from that CRP entity or that hospital. So this will all be a transparent process that we run through CRISP that everyone can kind of follow along the methodology. Are there questions here?
How does the 5% quality score incentive payment withhold interact with the minimum savings rate and the DIS savings, if at all?
Yeah, so that's a good question. The answer is it occurs after when those two checks are kind of made. So we will make sure that any DIS savings are offset and that a 3% savings are achieved before we kind of put it through the shared savings and determine the earn back. So by the time we are applying the clinical quality score, we will have already ensured that those two prior items that you mentioned, Jennifer, are met. Does that help?
It does. I'm just wondering if you achieve that 3% MSR, you know, by getting 3.1% savings, but 5% are withheld based on the quality assessment, does that wipe out your opportunity?
Yeah, no, so that's a good question. So again, the 3% is simply a check. So if you earn that 3.1%, you're gonna get 100% of that 3.1% back. We just need to ensure that you've met 3% prior to us determining that savings were made. And the reason here is, you know, there's random variation around, you know, costs as well. So, you know, there could be, we found in our analyses that simply doing a 1% withholding or simply earning 1% of savings could be due to random variation. So it's just a check to ensure that we're getting statistically significant savings in the program.
Hey Jennifer, this is Flo Daniel from the HSCRC. I just wanted to add a slight clarification to Maddie's answer. So the 5% withhold for the quality score is 5% of the incentive payments, not 5% of the baseline period cost.
Right.
So if you exceed the 3% threshold by, you know, 0.1%, the quality withhold is 5% of the incentive payment that you receive, not 5% of the baseline period cost, right? So it should be sort of irrelevant to whether you exceed that 3% threshold. Does that make sense?
Right, it does. Thanks, Will.
Yep.
Okay, great. Thanks, Will. Are there other questions here, or should we continue on? So this is just an example schedule of how we will aggregate the payments and figure out what is due. And I think there might be a miscalculation here, so my apologies. So in the baseline, so we will first, you know, take your baseline period and get those benchmarks for the episode target price, which will be trended forward. For purposes of this example, we used a trend of 0%. Say you have 25 episodes in episode A and 50 in episode B with a performance, your episode cost of $14,300 and a $9,500. So then we will aggregate, so that way we are weighting across episodes to a total performance year episode costs in line E. And then in line F, we will determine what is the aggregate savings or dis-savings achieved across each episode. So in both of these examples, we've achieved an aggregate savings that we will then check against that 3%. So this is, again, to Will's point, just based off of the performance costs, we will check if the 3% savings are achieved. If it is yes, 100% will be applied. The shared savings rate will be applied to 100% of these performance year costs. So this provider is in the 73rd tiered shared savings rate based off of the episode target prices. And again, this is a miscalculation, so my apologies. It should be a blended percentage of where the percentile rank is. So say there was a 73% percentile shared savings rate, and then we'll pay out a total incentive payment of $31,000. So this is how it kind of all breaks down, and I'm going to correct this in slides that go out, so that way it's a little bit more clear in the example. So I'll continue on. In terms of Dissaving Accountability, again, this is because we can't directly adjust fee-for-service payments. We will only be able to do lump sums, and we didn't want to be collecting from EQIP entities based off of their performance. However, it's really important to the state that we are driving meaningful improvements in cost and quality. So our dissaving policy in EQIP will help us to ensure that we are meeting outcomes in lieu of downside risks. So participants who create dissavings in a prior performance year will be required to offset those dissavings in the following year prior to earning a reward. So we will make sure that you have offset or paid back those dissavings from a prior year prior to applying the incentive payment methodology. And then the second piece of this is that if an EQIP entity's target price is in the lower two terciles of the tiered shared savings rate, so that means from 0 to 66%, and there have been 2 consecutive years of dissavings, this will result in removal from EQIP. And there are two rationales for this. The first is, again, you will be receiving QPP status for participation here. And so we don't want people, entering into the program simply for that QPP status without trying to drive results on cost and quality. The second piece, and why we kind of left the third tercile out of this, is that we do think it will be harder for the more efficient providers to provide meaningful savings if they're already fairly efficient. And so we do want to offer QPP status to those providers who are already very efficient in the state to participate in the program, because we do think that there's value in having them in the program as well. So there's a dual purpose to this, and we're committed to evaluating the results year over year and tweaking if necessary. But for initial performance years, this is the policy moving forward. Are there questions here?
Yeah, Dan Chaddock, I just had another question, and I apologize if I missed this, but how will the threshold be established that'll be used to determine the savings? Is it after the first year, or I just wanted a little clarification.
Sure, yeah. So we will determine DIS savings after the first performance year. And so we're going to, again, make sure it's not due to random variation. So I think there will be another threshold established there. But at this moment, because we are just in performance year one, we're not dealing with DIS savings. We're still working on that methodology. Okay, so that rounds out the total incentive payment methodology for the first performance year. We will send out these slides after. We're happy to walk through anything as well. And again, this will be a transparent reporting process through CRISP. So we're looking forward to having a lot of eyes on this and being able to discuss it statewide. So the next piece of this, and as I mentioned, we'll have a quality adjustment on the final incentive payments. We would like to walk through what that quality adjustment is based on, and then discuss future developments. So again, EQIP will be an advanced alternative payment model. And what this means is that participating care partners or individual physicians will be able to qualify into the quality payment program and benefit in a number of ways. So there will be a 5% incentive payment additional to EQIP incentives. There will be exclusion from MIPS reporting requirements and exclusion from the MIPS payment adjustments. So if you enter into EQIP, you move from the MIPS track to the AAPM track of the quality payment program. So this means that care partners who participate in 2022 will receive that lump sum payment from CMS in 2024 based off of their 2023 Part B services. So again, it is a bit of entrance into the program is preferable, right? Because in 2022, because you will not be paid out on this QPP program until 2024 if you participate. In initial performance years, and we've touched on this, all beneficiaries will be touched by a care partner. All beneficiaries touched by a care partner participating in an EQIP entity will be attributed to our advanced alternative payment model. So this means that much of the participants will qualify under QPP in initial performance years. We are committed to looking at this methodology consistently and ensuring that we are respecting and having some fidelity to QPP, and also really pushing providers to increase their participation in EQIP over the years. But again, because we're initially rolling this out, there's less episodes to participate in. This is an agreement that we've come to with CMS. So are there questions here, or?
I do think, though, the other thing that's important for everybody to know, and the goal is that this group, the EQIP group, is going to keep working and thinking about future episodes and future specialties as we move forward too. So it's not just adding in these 3 or 4, possibly thanks to Dr. Trumbull's good point, and maybe there's other specialties we haven't thought of, specialties. It's also the fact that we're going to be looking to add, and there are a lot of different bundles contemplated in the Prometheus codes, and I don't think that's exclusive. We're also open to other suggestions. I know we're very excited about working through Dr. Pine's proposal for the ER docs.
Yep, exactly. Part of the incentive of moving to Prometheus was that there are 97 episodes already available that we can bring online quickly. And then we do have the opportunity to work on some of our own, to Jean's point there. Okay, so we do have to, as a part of being an AAPM, there is a requirement to have quality measures on the payments. So we will have, again, this is where we get the 5% earn back for quality adjustment. So when we look at measures, we really aim to align with what had already happened in the CRP participation agreement and what is under our QPP qualification. We also wanted to align with CareFirst in that episode of care program to reduce the burden on providers, and then also tie into our statewide integrated health improvement strategy, which is a focus on 3 areas: maternal and child health, asthma, which includes asthma and other items, diabetes, and then opioid use disorders. So QPP AAPM standards have a couple of notes in regulation. The first is that they would like measures, when possible, to be outcomes measures. However, we really, there aren't a lot of physician measurable level outcomes-based measures. So in lieu of those, we had to apply a couple additional parameters to ensure, again, fidelity to the QPP program. So we wanted to maximize utilization of Part B claims measures as well to ensure that we could measure the quality performance and we didn't have to require any submission by EQIP entities. We also wanted to ensure that we had at least 3 measures per specialty area, which is the standard right now as a minimum or a floor in BPCIA and in EQIP. And then we wanted to max that out at 6 measures, which is the MIPS standard. And then lastly, we wanted to ensure, because we can't find an outcomes measure at the physician level, we wanted to make sure it was a high priority measure under MIPS. So that way we are, again, maintaining fidelity to the QPP program. So this is the measure selection standards that we first looked at, and then I'll talk through what happens in CRP already, so that way we can see the alignment there. So under the Redesign program, we have quality metrics across each of the 3 tracks. EQIP will be a bit different, again, as I mentioned, because we are not at the hospital level, we are operating at the physician level. So our other 2 tracks operate on a hospital level and episode specific. In EQIP, we wanted to, again, reduce the burden, but ensure that it was at the physician level and episode agnostic. So for all 3 specialties, there will be the same measures for the initial performance year. The selection of this is done by the HSCRC, though it is approved by CMS. So again, that's another background to all of this, is that we have to have approval for this quality measure policy with CMS. Again, since we couldn't rely just on NQF measures, we wanted to make sure that we utilized measures that were already included in MIPS payment. So that way we were aligning with items that were applicable to physicians. But we keep the 5% adjustment to incentive payment amount similar to EQIP. So it's a 5% earned back as an EQIP. We will be monitoring this in CRP reports and the state monitoring report to ensure that we are getting timely data out to CMS so that they can continue to approve this program. And then again, this will be QPP eligible. So this is just kind of the breakdown compared to other CRP tracks to again illustrate how we got to where we are going. So for performance year 1, when we put all the measures together, when we look at measures that are within the MIPS sets, specialty physician sets, applicable at a physician level, Part B claims measurable, and then again, meet those QPP standards, are high priority or outcomes, and we have 3 to 6 kind of available, and then meet HSCRC priorities, which is to align with CareFirst, be agnostic, so that way we avoid low cell size variability, and then also align with our population health strategy under the model. We came to 3 main measures. So the first measure is advanced care planning, and we'll chat through more of that definition there. The second is documentation of current medications in the medical record. And then the third is preventative care and screening for BMI. BMI is the measure that aligns with CIHIS. That's one of our goals under the diabetes area of CIHIS. So that was very important to us there. And then the other two are very good measures for procedure-based episodes, because if you are putting someone under anesthesia, these are two great items to ensure that are checked. So again, these will apply to all episodes in each of the 3 specialty areas, and they will be measured off of claims. So there will be no reporting required by participants. It will all be done at the HSCRC level, though we will tell you the results. Are there questions here? So moving a little bit further into definition, we will assess if the 3 measures were performed 365 days prior to the end of the episode. So we will take the end of the episode, look 365 days backwards, and determine if it was performed by any physician. And so this is really ensuring, for gastroenterology, maybe it's not a regular treatment that you are doing advanced care planning with your patients, but we would like to encourage that coordination and that medical record use to ensure that the primary care physician is doing these items. So that's really where we get here. And it's really also, again, focused on partnership across the system to ensure that these really great care management standards are being implemented, and then this population health follow-up is being added. So on advanced care plan, this is the NQF measure number 326. It's very easily look upable, which is not a word. You can very easily look it up. It will be the percentage of patients age 65 years or older who have an advanced care plan or surrogate decision maker documented in the record, or documentation that they refused it. So again, there will be dual credit there. If someone doesn't want an advanced care plan, we can't ding you that they didn't take one. The second one, documentation of current medications in the medical record, just as the percentage of visits for patients aged 18 and older for which a clinician attests to documenting a list of current medications using all immediate resources at the encounter. So that means the medical record, but then also a patient bringing in a bag of pills, that kind of thing, etc. For BMI screening and follow-up, again, it's the percentage of patient with a BMI documented during the current encounter within the previous 12 months, and it's outside of the normal parameters, and a follow-up plan is documented in the medical record, or it's outside of normal parameters and the patient does not medically qualify for BMI follow-up, say, because they have a medical condition that precludes them. And so again, all of these are listed in MIPS, and 2 of them have an NQF endorsement or are developed by NQF. So they're easily you can easily look at them and ensure, how we are calculating on the Part B claims side. So are there questions here?
Maddie, I have a question. So these are quality measures that will apply across all 3 episodes, correct?
Yes.
Okay. Will there be quality measures that are specific to the episodes?
No, so there will not be quality measures specific to the episodes for the first performance here. Right now, we want to get our sea legs underneath us, to use Jean's term, and ensure that this quality adjustment methodology applies to the incentive payment correctly. And then we are looking for episode-specific measures in the future, but again, that Part B claims measurable side is very important to us. We don't want to create a system where we are creating a lot of extra burden on EQIP entities to report to us what they are doing. We prefer being able to measure things based off of claims. And once you winnow down to that Part B world, it gets a bit smaller in terms of what's available from already endorsed quality measures.
Thanks. I understand. I think it's important that you try and make these programs as administratively easy as possible, but also want to make sure that there's the right quality measures to make sure that it's not just reducing cost, but
yes.
Preserving the integrity of quality care.
Yes, absolutely. And we'll talk, actually on my next slide, I kind of talk through future performance years. I think the Prometheus episode grouper provides us some opportunity there, and we can kind of think through as a group and collectively develop our own standards for quality. For the first performance year, again, this helps us get that QPP status. So we think as a baseline, this is very good, though, again, we really do want to expand upon this. And to your point, Nikki, ensure that this is not just a cost exercise, it's also a significant quality exercise. So on that note, in future discussions, we are going to finalize the CQS performance calculation after discussions with CMS. This will include, kind of the physician level of measurement, whether it's at the care partner or individual level or the EQIP entity level. The statewide level of measurement, whether it's for each episode of participation or aggregated within all episodes of one area, right? All episodes of participation. And then how we are going to do that statewide scaling methodology. So some fun analytics coming your way in future months, but those are the final pieces that we need to build out on this methodology. To Nikki's point, and as I've kind of teed up, in future performance years, we do want to work with this group and other stakeholders to refine this adjustment. The Prometheus episode grouper actually flags potentially avoidable complications on an episode specific level. So we will be able to provide the rates of say like pleural effusions back to providers in the program. So that way they can see, oh, my rate is a bit higher than the rest of the state. That's something that I need to follow up on or be more specific about. And in future performance years, we could potentially use that as a quality adjustment. We also are looking and working with our quality team at the HSCRC to think about outpatient and ambulatory surgery quality measures. So, our hospital program is pretty robust in the quality area, but as we start to shift procedures and think about lower acuity settings, this becomes a very important piece. We need to make sure that the quality of these settings is as high as in the hospitals. We also are looking for physician-focused outcomes measures, and whether this means building our own or, working with another national entity, we're still developing, but, thinking through, we have a lot of process measures as our baseline. How are we really looking at the outcomes of these episodes and ensuring that we have quality outcomes there? And then a big piece that we'd like to think about is an appropriate opioid use measure. These are all procedure-based episodes. So, thinking through, were opioids prescribed appropriately? Was there overprescription? That kind of thing is something, again, that aligns with SIHIS, our population health strategy as a state, and it becomes very important when you think about procedures. So that's where we're headed with this. We are going to update on the final calculation in the next couple of months, but over the next year, we're really hoping to use this group to discuss these following questions and update the quality policy in future performance years. Great. So we're just going to do a quick update on EQIP operations and timeline, and I'm going to turn it back over to Jessica to chat through our EQIP entity portal that we've been developing with Chris. That'll really be a great one-stop shop for entities participating in EQIP from the start of the program to the end. So she's going to chat us through that.
Thanks, Maddie. And yeah, as you mentioned, great summary. We are currently working with our colleagues at HMetrics and developing a portal which will live within the CRISP reporting services modules already, specifically for EQIP. And it will really house everything from your initial enrollment process, which includes selecting who is going to be a member of that EQIP entity. That's down to providing information, MPI numbers, contact information. If you choose to go with an administrative proxy, again, that portal will allow you to select that person, as well as provide full transparency on the status of that enrollment, since there are many steps that have to be done both in parallel and some done sequentially. You also, within that portal, will be able to actually select those episodes. And there'll be a lot of, there'll be some webinars and some demos going into it. Some of these selection processes will have a window where things can be modified, as well as a hard stop when sort of that selection is sort of finalized. Additionally, you will be able to view your baseline data depending the selection that you choose. And as the performance year continues, the portal will actually house where your performance is year to date, as well as providing you insights into what your incentive payments and savings that you may be hitting throughout the year. So a lot of analytics throughout that. We are currently in the process, as I mentioned, of developing it. It will be open for people to both log in and to begin that enrollment process in July. I would like to note that because it is part of the CRS suite or the CRISP reporting services suite, there is a vetting process or credentialing process, should I say, associated with accessing that. So what we can do prior to the July opening of the portal is ensuring that any individual members or administrative proxy, whoever that may be, has access to the CRS suite, so that once that window is open, people can start right away. Since again, there is that only 3-month window until September 1st to be able to indicate wanting to participate in the program. We will have specific webinars about actually demoing the portal and how to go through selection. There additionally will be help desk type things and user guides that will all live within the program. And then once performance year actually starts, the portal will also have some links to some learning system engagements, ensuring that our calendar of upcoming deadlines is up to date. And again, providing that transparency across the different steps to ensure that our users and our administrators have the resources that they're needed to be as successful as possible in this. So more to come, but that's where it will live.
Great, thanks, Jessica. So I think also in future months, as Jessica mentioned, we want to kind of walk through this portal and show you some screenshots and talk about the processes there, as well as provide some materials that help everyone navigate. So that is what we will be bringing to this group in the next couple of months as well. Okay, so a more detailed timeline here just to close this out. So again, we're still finalizing that last quality payment adjustment. We're hoping to do that within the next month or so and then update this group. And then throughout May and June, we're going to really be hitting the ground with EQIP recruitment, different information sessions, and ensuring that everyone is already credentialed with CRISP. So already has a participation agreement signed with CRISP. So that way we can get them into the portal when it opens. So on either of these 2 points, if there are questions, please reach out to the CRISP email box that I'll present again at the end, but we really are hoping to do all hands on deck and get as many physicians into this program for year 1. On July 9th, our care partner portal will open for enrollment and baseline episode experience will be available. So we will be able to kind of show you what episodes you are eligible for as an EQIP entity based off of the NPIs that you submit into the portal for enrollment. Again, we will have to have the list of names and NPIs that are intended to be in each EQIP entity by September 1st. This is when we will close that kind of participation side of who would like to be in for vetting to CMS. So we will be then submitting that to CMS to figure out who is up to date in PICOS, and then we will provide that information back later in the year. From September 1st to December 1st, we will be doing that contracting side. So as I mentioned, contracts do not need to be signed by September 1st, but we will be finalizing our payment operations, finalizing those contracts between the CRP entity and the individual physicians, and ensuring that all of the participants submitted by that September 1st deadline are vetted and approved by CMS. So we're hoping to have that information finalized by December 1st. So that way the program can start on January 1st of 2022. The Care Partner participation opportunity will be annual. So if people don't get in by this timeline over the next couple of months, there is another participation opportunity that will open again in July of next year for 2023. And then the first performance analytics will start to trickle in and be available again due to run out in March of 2022, and we'll be updating it thereafter. And then again, we will be paying out initial first year incentive payments by July 1st of 2023. So some of this is all, can shift a bit, and we'll keep this group as up to date as possible, as well as posting it on our website at HSCRC and making sure that our learning system is all up to date, so that way everyone has the most recent information. But this is where we stand as we look at it now.
Yeah, I want to make a couple quick points here. When we did Maryland Primary Care, the first year, there were quite a few practices, particularly smaller practices, that were thrown out for PICOS not being correct. So that's something, particularly for those of you who partner with smaller private practices, we should make sure they check, because it's very easy to fix. And if you're thrown out, you're thrown out, you'll lose a year of participation. The second thing is MedChi has a team working with Chris, Colleen George and Jeff Bem, who can help anybody who does not have a Chris participation agreement and walk them through it. So that's another place you can go to get help. Again, this will probably be an issue for some of the private practice physicians listed in the hospital-based ones, but we don't care where you are, we're happy to help. And the third point that I wanted to make about this next step and timeline is Maddie, Jessica, Tequila, and I are going to be setting up meetings with the Maryland Orthopedic Association, the Maryland Neurosurgery Association now, with Dr. Trumbull's good point earlier, the Maryland GI Society, and the Maryland Cardiology Society, and having some kind of joint calls to really focus on those specialties. If anyone would like to help us, maybe I'll ask MHA to help us a little bit if they don't mind. We would like help encouraging folks to hear about this. This is a really good opportunity, and we want to make sure that we make people aware and don't miss the opportunity because the timeline is so tight.
Yeah, and Jean, if I can just jump in and just add one comment, I think one of the things that we can do is also maybe put something together for what folks can be doing now, because there's a lot of steps that Maddie and Jessica alluded to that folks can start working on now to avoid any problems during that participation enrollment window. And so maybe in the next meeting, we'll focus more narrowly on that point in particular, so that we can start to get people doing some of that groundwork that'll be, really critical and hopefully alleviate any problems that could come up later. So we can put that together as well.
Absolutely. So our last slide is just a thank you to everyone on this group. I know it's been a longer process for us to get all these steps put together, but I think the result is going to be a great program for the Maryland Total Cost of Care model, and then, physicians statewide. So we're very excited about it at the HSCRC and Chris side, and we're thankful, to our partners with Jean, but also our partners at CMS, our partners at CareFirst, our partners at Change Healthcare, our partner hospital that we're still bringing online. But a lot of people have gone into making this what it is today and allowing us to be able to roll it out for next year. So we're very, very thankful on the HSCRC side. In terms of contacts, if you guys have specific questions to any of our comments today, here are the three of our emails, Jessica, Tequila, and myself. Enrollment inquiries and any general inquiries, please feel free to reach out to this CRISP inbox. It can be your one-stop shop for anything. If you have questions about the CRISP side, the policy side, the CMS side, any of it, send it to that inbox. It's a really great resource, and we'll make sure you get to the right place so your questions are answered. And then again, our webpage is up to date now. We will be putting these slides up as well as Jean's recording and ensuring that any program materials that'll be helpful for enrollment end up on this page. And so please check it regularly, or if there isn't something up there that would be helpful, please let us know. We're happy to put as much information out there as we can. So with that, I think we're all set, and I can give everyone some time back in their day. And there are some late breaking questions and comments that we should take.
And just also before we close, I do want to just acknowledge and thank Maddie for all of her work in leading all of the efforts around the development. As she said, there's a lot of people we've been working with, but Maddie and the efforts that Jessica have put into all of the work and the thought around EQIP, along with Will Daniel from our team, just really a very thoughtful process to try to make this one as easy as possible for the docs to participate in, but two, again, sort of fostering this idea of these are the types of programs that ultimately yield better outcomes and more focus on value. And so I just want to thank all of our team who's worked sort of behind the scenes to pull all this together. So thank you, Maddie.
Thank you, Tequila. Okay, Jean, unless you have anything else, I think
we're good.
Free people.
I love getting a half an hour back.
Yes.
All right, guys. Everybody have a great weekend.
Thank you.
Thank you.
Thanks, everyone. Take care.